We'd like to welcome up our very first speaker for this morning. She is the head of the Breast Cancer Center at St. Luke's Medical Center in Quezon City. Please welcome Dr. Macel Pagdanganan.
Good morning. I would like to thank the organizers for inviting me this morning. This topic is very close to my heart and all of our hearts. So it's about priority one, my body, my breast. I'm going to talk about screening for breast cancer for average risk women. As I've seen the program, and somebody else is going to talk about screening for high risk women. Next slide, please. The breast is something that our society has mystified and even obsessed about, and so it's very important. So it's actually a symbol of femininity and nurturing. Next slide, please. And so before I start, let me just go with you through the anatomy of the breast. As we can see, there is the breast form, and there's the areola and the nipple. Next slide, please. But inside the breast, it's a lot more complex. Like those violet things are lobules or breast glands that form the milk, and then those violet lines going into the nipple are the ducts that bring the milk outside for the baby to suck. In between there is about 15 to 20 ducts opening out into the nipple. And the white structures in there are the connective tissues which give our breast support and form, and in between are the fat cells. Next slide, please. So there are usually normal breast changes that we go through normally that we should not be worried about during puberty. Girl will undergo enlargement of the breast. First, it's going to look like it's a mass underneath the nipple areolar complex. It's a mistake to take it out, as the girl's breast will not anymore develop in life. During menstruation, just before menstruation, there will be some swelling and enlargement of the breast and lumpiness in preparation for the possibility of pregnancy. Of course, the breast will enlarge during pregnancy and lactations, as the glands are supposed to enlarge to produce milk. And upon menopause, there's going to be some sagging of the breast, as some of the connective tissues and the lobules will atrophy because there is no more need for the patient to breastfeed. Next slide, please. Okay. Benign breast diseases are very common. They're usually aberrations of the normal development and involution of the breast. So we need not be afraid, because a lot of patients would say they don't want to submit themselves for examinations as they are afraid of what will the doctor find out in their breast. But 54% of those abnormalities are actually fibrocystic changes. It used to be called fibrocystic disease, but since nothing is usually done in them, the term had been changed to fibrocystic change. And we should be assured that 70% of all breast biopsies or minor surgeries result to a pathology reading of benign breast disease. Next slide, please. There's a widespread acceptance that breast cancer is an important health problem worldwide. In all of the developed and less developed countries, it is the most common cancer in women, and it is the second leading cause of cancer deaths in women. Next slide, please. In the United States, it is estimated that there will be 232, a little over 200,000 new cases of invasive cancer, and that about 1 out of 12 women will eventually develop invasive cancer during their lifetime. This is from the American Cancer Society estimate. Next slide, please. Here in Guam, this is the figure that they've published in 2009. Breast, just like the rest of the world, leads the incidence of cancer in women with a percentage total of 30%, and it ranks second to lung and bronchus as the cause of cancer mortality, percentage total of 20.3%. Next slide, please. So with all of these figures that had been presented, the next question that comes to mind is, how do we prevent breast cancer? Next slide, please. So in order to prevent, we should know the cause. And however, there is no single cause or group of causes that is attributed to causation of breast cancer. So that does mean that there will be no prevention. Next slide, please. In looking for the cause, they have come up with risk factors. Primarily, number one is sex, as being female predisposes us to the development of breast cancer. But males also develop breast cancer. However, it is very, very rare in that for every 100 women developing breast cancer, there is only one male having it. Age, breast cancer is a disease of the aging population. So the older you get, the more at risk you are for developing breast cancer. Family history plays an important role also, especially if you have the gene BRCA1 and 2 and proven to be positive. Personal medical history of previous breast cancer on the other side, or cancers of the reproductive system like the ovaries and the uterus also predisposes one to the development of breast cancer. Estrogen exposure is an important risk factor, so that those who have had their menarche, or the age when they started having menstruation at less than 14 years old, and when they had their menopause, meaning there's a very long period wherein they are menstruating, then they're predisposed to developing they have a higher risk of developing breast cancer. Also, if one has given birth past 35 years old, first birth, then they are at risk. And upon extension of the estrogen exposure by taking hormone replacement treatment, then one is also predisposed to developing breast cancer. If we look at this list, the most common risk factors are sex and age. And it seems that we can't do anything about being female and getting older. So it means that all of us, all women, are predisposed to breast cancer. Next slide, please. So, but it doesn't mean that if you have the risk factors, you will develop breast cancer. And if you have no risk, it doesn't also mean that you will not develop breast cancer. Next slide, please. Okay, but it is comforting to know that if diagnosed really early, there will be less invasive treatment options, and the results of cure are better, and survival rates are higher. Next slide, please. Next slide, please. Okay, this table here shows the 5-year relative survival rate according to stage. As we can see, stage 0 to 1, if diagnosed that early, will have a 5-year survival rate of almost 100%. Next slide. So breast cancer as yet cannot be prevented. Incidence increases with age. Early diagnosis translate to better outcomes or higher survival. So at least we can do something by making sure that we get diagnosed early. Next slide, please. So there has been a widespread acceptance that breast cancer screening is a part of a public health strategy to reduce breast cancer mortality. It is usually performed in asymptomatic women, and its aim is early detection and appropriate treatment. So this is what we call secondary prevention. Next slide, please. So there used to be 3 components of breast cancer screening. It used to be breast self-examination, clinical breast examination, and regular mammogram. However, there had been a move to remove breast self-examination, as studies have shown that it resulted to greater anxiety among women and more biopsies. But those who oppose this removal from the breast cancer screening component are saying that these studies that had been done are flawed, and breast self-examination is important in that, especially for those women who will develop breast cancer in between checkups. So instead, the American Cancer Society has come up with promoting breast awareness, which means patients should be advised to know their risk, to submit themselves to screening, and to lead a healthy lifestyle. So women should be informed about the benefits and limitations of breast self-exam and be able to choose whether or not to practice breast self-examination. Clinical breast exam and regular mammogram are the 2 other components of breast cancer screening. Next slide, please. Okay, these are the questions that I will try to answer. What is self-breast exam? How do I examine my breast? What am I looking for, and when should I do it? A self-breast exam is an examination of one's breast, preferably every month, to find out if anything new has developed or has come up. The next slide. So I am going to discuss this for those of you who would want to practice breast self-examination. Um, Next slide, please. First step is you look at yourself in the mirror, face the mirror, and see how your breast looks like. It should look the same. Probably as you get older, sag a little, but it's okay for right and left breast not to be of the same size. In fact, there 1 to 2 bra sizes difference between the two breasts is actually normal. One may hang lower than the other one, but subtle changes may be emphasized if you try to reach up and tighten the muscles underneath. Okay, what we're looking for are dimples, lumps that may show on the skin, and then put your hands on the hips, tighten the muscles of the chest wall, and move the elbows forward. Okay, next slide, please. And then one can do the self-breast examination in the shower with soap. It's easier to feel something, even the ones that are located deep in the chest wall. The usual, one needs to use the hand of the opposite to the breast, flat surface of the 3 middle fingers. One needs to examine everything, all the area that is bounded by the bone in here, the collarbone, the area where the lower part of the bra rests, from the bone in the middle up all the way up to the axilla. So one needs to make sure that all of the area defined by those boundaries are well examined using the opposite hand, flat surface of the 3 middle fingers, with the hand of the same side at the back of the neck. So there are 2 ways by which one can do it. You can do it either the lawn mower way by going from the top in the middle, going down. You can feel it lightly and then a little deeper and then very deep to be able to feel the different layers of the breast. So one needs to go from the top to the bottom, and then when you reach the bottom, go up again, making sure, like I said, to go through everything, through all the areas, just like what we do when we mow our lawns. And another method is to do it like a clock. So you start from 12 o'clock position, do the examination, going around 1 o'clock, 2 o'clock, all around. When you reach 12 o'clock, you go a little near the nipple and then go around again until you've covered the entire area, making sure not to forget the axillary area. Next slide, please. After you've done it in the shower and you've dried yourself, you still need to do the same thing lying down, because when one lies down, the breast tissue gets thinner, and so one would be able to feel deeper into the breast. Okay, next. The secret here actually is to be familiar with how your breast feels. If you feel anything on one side, check the mirror image or the other side. If there's anything similar, especially here near the upper outer quadrants of the breast where the breast tissue is thicker, then if there's a partner, then it's nothing that one should be worried about. Another tip is one should be familiar with how your breast feels, so that if there's anything new, then one will be able to recognize that it was not there before, and so it should be something that one needs to show to her doctor. Next slide, please. So what are we looking for? We're looking for a firm lump or thickening that was not there before, change in the size or shape. Some breast malignancies would actually cause a rapid decrease in the size of the breast. Asymmetrical. Like I said, if it's been like that before, not of equal sizes, the left and the right, then it's okay. But if suddenly one grows to be smaller or markedly bigger than the opposite side, then it's a cause for concern. Change in the skin texture or color, like if there's redness, swelling, warmth of the breast, one side of the breast, lump or mass in the axilla or skin dimpling, nipple change, nipple rash, wounds, or scaliness of the nipple, then those are the symptoms that need to be looked at. Or a sudden nipple discharge. It may be bloody or dark colored and just coming out from one side of the breast. Next slide, please. Okay, this has been studied that women who practice monthly breast exam would actually discover their nodules one-third of a size, as opposed to those who will discover their breast nodules when they're not practicing breast self-examination. It's a procedure that is simple and painless, and so it can easily be done in the house. Next slide, please. So, but I see a lot of patients who don't want to do their breast examinations because they're afraid of what they're going to find. But majority of all breast lumps are benign, and if they are not, more than 90% of those breast nodules are discovered by patients themselves. And it is good to be able to discover a malignancy earlier, like I said, because those that suddenly come out in between checkups are the ones that are relatively more aggressive and so needs to be looked at immediately. Chances are, when you go to your doctor, they will say that it's just benign, so that will give you peace of mind. And if it's something of concern, then it's good that it's going to be treated right away. Because like I said, if breast cancer is found early, it is usually successfully treated. Next slide, please. When should I do breast self-examination? As I mentioned earlier, just a week or two before menstruation, breast can get a little more lumpy or swollen, tender. So I usually advise my patients to do their breast self-examination day 10 to 15 of their menstruation, counting from the first day. So that's day 1. So when you do it a week after, or day 10, like I said, day 10 to 15, the breast will be less tender, less lumpy, and so one would be able to examine the breast more. How about for non-menstruating women? I used to tell my patients to pick a nice number from the calendar as to when they will do their breast exam, but there's a tendency for us to forget dates. So now I tell them to just pair doing the breast self-exam with something that you usually do every month. So, for example, when you pay your bills, electric bills, then that's the time that you do your breast exam. You get reminded. Or when you total your checkbook, so it's also a reminder that you do your breast exam. So try to make it a habit. Next slide, please. Clinical breast examination is one that is done by a physician, and it should be done every 3 years for women 20 and up to 39, and yearly from age 40 onwards. So what do we expect? We expect that you get examined very well by your physician, sitting up and lying down. And next slide, please. So mammography is really a part of screening. It's a well-established imaging modality. It uses X-rays to come up with images of the breast like this. There are usually 2 views that are taken of each breast, one from the top. So we can see how it is done up there, and then the image that is produced. This one is a little bit harder to do, the mediolateral oblique angles, but then one can visualize the axillary tail of the breast with this view. So this, for screening mammography, you only take 2 pictures each of the breast. Next slide, please. It is actually safe. Of course, there is radiation, but with the newer machines now, there is less radiation. And if the breast gets really compressed, there's radiation also. They say that there is an accumulation of radiation through the years, but then it has been proven that the benefits that you get from doing mammography far outweighs the risk of being exposed to radiation. So what usually happens during an examination is one is made to remove their upper clothing. So make sure that you wear something to the mammography facility that is easily removable. don't use perfumes, lotions, powders, or antiperspirants, as the chemicals contained in these products may actually show up on the mammogram that will make it hard for the radiologist to interpret. Does it hurt a little? It's actually more of a discomfort, but the compression is really necessary to come up with better images and to lessen the radiation that one will get from the mammogram. Next slide, please. So we do need a mammogram because it can pick up cancers 1 to 2 years before these cancers are felt by the clinical breast exam and the breast self-exam, and even by the ultrasound. Cancers that are usually discovered through the mammogram are usually stage 0 to 1, which, as we saw in the earlier table, would actually have a 5-year relative survival rate of 99 to 100%. So mammography has very high sensitivity and an even higher specificity, and it is the only imaging modality proven to reduce breast cancer mortality by 20 to 40%. Next slide, please. Limitations, however, there could be false positives, false negatives that can be as high as to 7 to 15%, especially for women with very dense breasts. When you say dense, this applies to almost all Asian women, wherein there is more breast tissue than fatty tissue. And since dense breasts appear white on the mammogram, and the signs that we look for of malignancy are actually very small white dots, then this could easily be missed in mammograms of women with very dense breasts. So these problems are addressed by use of digital mammography, which is what most of the centers have right now, or supplementing it with ultrasound, or for women with have high risk for developing breast cancer, by use of the MRI. Next slide, please. Digital mammography usually come up with better images, or will pick up cancers better for women who have dense breasts, younger than 50, or those who are pre or perimenopausal. It delivers less radiation and shorter compression time. For the radiologist, digital mammography has the advantages of, because of it being digital, then the radiologist can actually manipulate the images. They can lighten, brighten the images, or darken them, or even reverse the projection with regard to the color, and they can even enlarge or focus more on the areas that they want to see better. Next slide, please. Just to illustrate, these are your 2 mammograms of the same person. The one is taken by an analog mammogram, and this on the picture near me is the one taken by digital mammography. So there is actually more detail when you use digital mammogram. Next slide, please. So the breast cancer screening mammography guidelines dictate that annual screening for starting at age 40 for women with average risk of breast cancer. We can usually start younger for women with increased risk, like those with previous breast cancers or cancers of the reproductive system, those with strong family history or with genetic predisposition to malignancy, those with prior biopsy-proven high-risk lesions, and prior radiation to the chest. There is actually no upper age limit to doing the mammography. Most studies have involved women who are 65 and younger. But the rule of the thumb is, as long as these patients are in good condition and you think will be able to undergo, say, biopsy or further treatment, should we find out something, then they're actually eligible to undergo mammography. Next slide, please. Ultrasound is used as a diagnostic modality, as an adjunct for adjunct to mammography. The additional cancer detection rate is 4.2 per 1,000 cancers. Although the use of ultrasound will result to unnecessary biopsies. As a standalone screening procedure, breast ultrasound has very high false positive rates and so very low specificity rates, so is not advisable. Another thing, it is usually very dependent on whoever is doing the ultrasound. So the results are not that uniform. Next slide, please. So on that side is a 2D ultrasound. Now they're trying to look into the 3D ultrasound, whether it will eliminate some of the differences in the reading and the results because of it being operator dependent. Next slide, please. MRI is more sensitive than mammography, but it has a very low specificity rate. It is usually used to evaluate augmented breast or for those with advanced malignancies to assess its response to chemotherapy. However, it can be very expensive as a screening tool, but it is now being used for screening as an adjunct for women at high risk for developing breast cancer. Next slide. Recommendations. It is recommended to be used for women starting at age 30, women that are BRCA mutation carriers, primary relatives of those with very high risk of developing breast cancer. Okay, next slide. Insufficient evidence to recommend for or against those with lifetime risk of 15 to 20%, those with previous biopsy results of LCIS, ADH, those with very dense breast or personal history of breast cancer. And definitely they cannot be used for those average risk women. Next slide, please. No other screening modality to date should replace mammography for high-risk women. Supplemented screening may be warranted, ultrasound for those with dense breast, but no other risk factors. MRI for high-risk women. Next slide, please. Okay, let me just go through this breast cancer myths. Well, from the lecture, I've already told you that not breast cancer can develop not only in women but in men also, although the probability is lower. So only women with family history are at risk, because this is not true, because more than 50% of those developing breast cancer are those without family history. So older women are more likely to get breast cancer than younger women. It is not contagious. Next slide. Not all breast lumps are cancerous. A woman with lumpy breasts increases a woman's risk. So this is not true. And small-breasted women can get breast cancer. Next slide. Coffee drinking does not predispose you to developing breast cancer. Antiperspirants will not cause you to develop cancer. Breastfeeding will not cause cancer. Nipple discharge, most of the nipple discharge usually results because of a condition that is benign. Next slide. Underwire bras cause breast cancer. Actually, this is not true. Whatever the type of your bra is, or if you don't want to wear a bra, whether it's nylon, cotton, front bras or back bras, it will not predispose you to developing breast cancer. Injury to the breast causes breast cancer. This is actually not true. But a lot of patients believe this because most of them who are not doing breast exam, and then one day they get hit by their grandchildren, or they hit themselves on the doorknob and then they massage the area that had been hit, and then they discover something. What they don't know is it has been there even before. It's just that they're not doing their breast exam. That's why it went undetected for a long time. And only when they were hit or when they were injured, that's when they found out that there's a mass growing in there. Oral contraceptive pills cause breast cancer. There's actually a study that says that if you take oral contraceptive drugs, your risk for developing breast cancer increases. It's true, but the effect is only during the time that one is taking oral contraceptive drugs. And after 10 years of stopping it, your risk goes back as those of the average woman. This is not actually particularly significant because those who take oral contraceptive drugs are usually the younger patients, wherein to start with, the risk for developing breast cancer is not very high. Mammogram definitely does not cause breast cancer. And it is not true that if it is painful, it is not cancerous, because those lesions that are already very big usually will cause you pain. And actually, one of the things that will make a doctor try to work up patients more if there is a consistent or persistent pain in just one area of the breast. Next slide, please. So this is redundant, but I'll read it anyway. Important reasons why we should practice breast cancer screening. Well, finding it early can save our lives. As we get older, the risk increases. More than 50% have no family history, and early detection means less surgery, better chance for cure, higher survival. Next slide. Okay, so this was outlined earlier. Next slide, please. Next slide. Okay. Of course, we also, it was mentioned for breast health awareness that we try to make good lifestyle choices, such as taking good diet, limiting fat, red meat, alcohol, as alcohol increases the estrogen level in the blood, so that will actually increase your risk for developing breast cancer, and for one to stay physically active and to maintain healthy weight. Next slide, please. So we'll continue to diagnosing breast cancer. Next slide. Next slide, please. Okay. So since, well, if we are able to implement breast cancer screening, we will be diagnosing breast cancer or picking up this potentially cancerous lesions by mammography, meaning we cannot yet feel them, or even if we do operate, we cannot see them using the naked eye. So more and more, we will be using image-guided breast biopsy procedures. Next slide, please. So doing biopsy on the breast, next slide, has developed into the more invasive surgical type, and then using different sizes of needles. Next slide. So I've outlined the different options for doing image-guided breast biopsy. For the specimen collection, we can do it surgically, which is the invasive way, or using a needle to take samples of the breast tissue using a very fine needle, core, vacuum-assisted, and then using the different modalities of imaging modalities to guide us as to where we should take specimen. Depending on on which imaging modality best illustrates the abnormality that we're seeing. Next slide, please. So this is actually the difference between an invasive surgical and a minimally invasive. Surgical needs to be done in the operating room, while the needle biopsy can only be done in the breast center or the clinic. Invasive or the surgical needs general anesthesia, and then although it has the highest accuracy because one removes the entire mass, but it also results to scarring and disfigurement, and the scars that are developed may interfere with subsequent imaging done on the patient. Some of the patients would want to be admitted and will have some degree of post-operative pain for the surgical modality, and a second surgery needs to be done to clear the margins and end up being more costly. Next slide, please. Okay, so core biopsy accuracy approaches that of the surgical biopsy. Next slide. Okay, so for surgery or surgical biopsy of lesions seen only on imaging, one will need an insertion of a wire or a needle to identify the area where the lesion is. So the patient will undergo this localization under local anesthesia before patient is brought to the operating room. Next slide. So this is an example of a mammogram-guided needle localization biopsy. There's a density in there on the mammogram, and so the needle was placed to um, so that it will serve as a landmark as to where the surgeon needs to remove the tissue. Next slide. Okay, this is ultrasound guided with the use of the ultrasound. We can see the white line there, that's the needle being inserted. Next slide. Next slide, please. Okay. For the different, for the minimally invasive biopsy, we use several sizes and types of needle. Fine needle is just using a syringe, but it is used mainly for cyst aspiration or axillary lymph node biopsy using ultrasound guidance in this slide. The problem with fine needle biopsy is we only get cells, not tissues. Also, it is only useful if the biopsy will prove to be positive, but a negative result does not mean anything. Next slide, please. For the core needle biopsy, a tissue is taken. This is almost concordant with surgical excision. Okay, next slide. That's ultrasound guided. Okay, vacuum-assisted breast biopsy system is actually a core needle biopsy method, way of doing the biopsy, but partnered with a vacuum assistance. So with this one, you only insert the needle once, and we get bigger tissues and contiguous tissues at that, so the pathologist will be able to interpret better. Next slide. So this is an example of a vacuum-assisted breast biopsy system. In fact, for benign lesions, one can actually take out the entire mass without patient undergoing surgery, mass up to 3 centimeter in size. Next slide, please. So comparing the different core needle biopsies, we have here the different gauges. The 11 and the 8 you only use with vacuum-assisted. But if we compare for both gauge 40 needles, the core and the mammotome, we get bigger tissues. So remember that the bigger the tissues are, the easier it is for the pathologist to interpret the reading. Next slide, please. So for the imaging guidance that we will need, like I said, ultrasound, advantage of ultrasound is we can actually see the lesion as we're doing the biopsy, and there's no radiation involved. Multi-directional sampling possible, and cost is very low, and the procedure is very short. As opposed to mammogram, there's no real-time visualization. There is discomfort from breast compression. The procedure actually takes longer, and patients are not able to move for a certain period of time because we don't want to lose our target. The only advantage to using the mammogram as a guidance if in cases wherein the lesion can only be seen on mammogram. And so potentially, these are the lesions that we can catch earlier. Okay, next slide, please. So this is, again, mammogram-guided needle localization. So after we've taken out the area of concern, we again biopsy, we again x-ray it to make sure that we got what we wanted. Next slide. With the stereotactic biopsy, this is mammogram-guided needle biopsy. We have the upright unit and the prone unit. The advantage of the prone unit is that we don't need to pull the breast because it will naturally go down with gravity. And then the patient cannot see what the doctor is doing underneath. And there's less chance for us to prick the lungs because the chest wall is up there and the area where the working area is underneath the table. Next slide, please. Relative contraindications, if the patient cannot tolerate prone position, that's how long it's usually done, 30 to 40 minutes, but usually it can be done in 15 to 20, depending on the location of the lesion. If the lesion is too close to the chest wall, we cannot also do the stereotactic or in very small breast. Next slide, please. So this is how we do it. Okay, another advantage of doing the stereotactic is we can actually put a marker after the procedure to identify in cases wherein we actually removed all the calcifications. The picture farther down there are is the picture of the breast tissue with the suspicious microcalcifications, and then we placed a marker just in case the patient would want breast conserving surgery, then we can identify the area where malignancy was found. You can see the scar up there in the picture of the patient. It's very small, unlike with the surgical biopsy. Next slide, please. But the rule of thumb is for ultrasound visible abnormalities. Say if we see something on the mammogram, but we identified it on the ultrasound, we'll do still ultrasound guided with or without vacuum assistance. But for mammogram only visible lesions, we do stereotactic needle biopsy. Next slide, please. Okay, very high sensitivity. Next slide. With diagnosis, should we get second opinion? Yes. Not that we expect another doctor to tell you something different, but in order for you to accept what you have, and if one has concerns about treatment plans or one is uncomfortable with your doctor. Thank you. Next slide, please. Okay, St. Luke's Breast Center has been accredited by ACR. Facilities had been found to have adequate personnel, good monitoring of equipments and personnel readings for ultrasound, mammogram, and stereotactic breast biopsy. Next slide. We are the only facility outside of South and North America to have been granted accreditation as Breast Imaging Center of Excellence. Thank you very much.